Well, the time has finally come for Dr. Happy Hour to present at Grand Rounds. For those of you who do not understand my reference to Dr. Chris Wiegand in that manner, let me read an email sent this afternoon to the members of our department. I quote, "Happy Hour this week will be at the Shanty, 4th Avenue and 9th Street after my Grand Rounds. Pay attention at Grand Rounds for an opportunity to win a free beverage. Chris." It's not only a pleasure to welcome Dr. Chris Wiegand to Grand Rounds, but also a special guest, Stephanie, who I assume is here in a supportive role. Is that right? Okay, good. Dr. Wiegand is a graduate of the Virginia School of Medicine in Charlottesville, Virginia, where he incidentally and not surprisingly was elected to be the class social chair from 1996 through 1999. In his years with us in our program, he has been very busy both within our department and apparently outside our department as well. In addition to attending his residency training requirements, he serves as an instructor for the psychopharmacology seminar for third-year medical students. He is a volunteer facilitator for the first-year medical students work group, and also this year he received the Pfizer Resident Award at the APA annual meeting in Philadelphia. Last year he served as a member of the Internal Review Committee for the Department of Neurology, and also was a member of our department's Child and Adolescent Faculty Selection Committee and a member of our Resident Selection Committee. In 2000, he was the Eli Lilly Fellow at the U.S. Psychiatric and Mental Health Congress. He additionally participated in a psilocybin study with Dr. Moreno for the past 2 years, which, along with his numerous happy hour engagements, I'm sure, has influenced his choice of topics for this afternoon's Grand Rounds. His talk is entitled "The Therapeutic Potential of Psychedelics." Dr. Wiegand.
Thank you, Dr. Mishashek, for that warm welcome. I'm sure Stephanie's thrilled about that, too. I have to attach my microphone. I'm assuming that's good. Okay, so as Dr. Mishashek said, the title of today's talk is Therapeutic Potential of Psychedelics. But I'd like to start out with a picture of Dr. John Mishashek in rare form.
I guess I went a long time without anyone seeking me.
I was hoping that you'd be introducing me and not Chelsea. So the next thing I want to do is I want everybody in the auditorium to raise their right hand and to put their right index finger in the air. Everybody do this. In order for it to work, everybody's got to do it. Now with that right index finger, I want you to go to your cell phone or pager and put it on stun vibrate so it does not make a noise and distract me. I hate it when that happens. So today I'm going to go over, first of all, address the topic of what are psychedelics, how do you define the term, what chemicals exactly constitute a psychedelic, what are their pharmacological actions, what is the psychedelic experience like and what does that consist of. And finally, we'll talk a bit about adverse effects of psychedelics. We'll then talk about the history and prehistory of use of some of the major hallucinogens. We'll move on to talk about the clinical trials of the 50s and 60s, the age of psychedelic prohibition, and the more recent clinical trials from the 1990s until the present. And then finally, I'll talk about our own research. From the Greek, it literally means mind manifesting or mind revealing. The Oxford English Dictionary defines psychedelic as producing an expansion of consciousness through greater awareness of the senses and emotional feelings and the revealing of unconscious motivations. Psychedelics go by a variety of other terms as well. The term hallucinogen, psycholytic, psychotomimetic, entheogen, empathogen, and enactogen are also used. Which term you use depends on which one you favor and also how you're using the chemical. A more pharmacological definition of psychedelic is any agent that causes alterations in perception, cognition, and mood as its primary psychobiological action in the presence of an otherwise clear sensorium. The chemical families which constitute psychedelics, there are 5 main families. The tryptamines fall into the bigger family of the indole alkylamines, and the tryptamines include DMT, psilocin, psilocybin, and the active ingredient in bufo toad venom, which is 5-methoxy-DMT. The next family is the ergolines, which includes LSD and its natural and synthetic analogs. The next group is the beta-carbolines, which include harmaline, which is one of the active ingredients in ayahuasca. The phenethylamines include mescaline, which is the active ingredient in peyote. And finally, we have the phenylisopropylamines, which includes DOM, which was popular back in the 60s, also known as STP. Today, we're going to talk about psilocybin, LSD, and mescaline because these are the most widely used psychedelics, and we have the most clinical and research experience with them. I'm not going to talk about MDMA or ecstasy because that is an entire lecture unto itself and would make this lecture go way too long. This slide should give some of you flashbacks to organic chemistry, but what we're looking at here is the chemical structure of serotonin, which is one of the endogenous neurotransmitters. This is the chemical structure of psilocybin, and if you look, it's not hard to see the homology between the two chemicals. If you squint your eyes a little bit, you can look at mescaline and see, the same 6-carbon ring with the branching chain. And if you squint really hard and look at LSD, you can see the homology as well. So all of these drugs that we're talking about are potent agonists at the serotonin 2A, 2C receptors. The initial response after ingestion is that of sympathetic arousal, followed by the actual psychedelic experience. The effects of most of these drugs last anywhere from 4 to 12 hours, with the exception of DMT, which lasts about 30 minutes. 5-methoxy-DMT lasts even shorter, about 10 to 15 minutes for the peak experience. All of these drugs exhibit tolerance and cross-tolerance. There are no withdrawal symptoms, and there's no evidence of physical dependence. There have been no deaths recorded due to the direct physiological effects of these drugs, even in accidental massive overdoses. Also, it's interesting to note that chronic use of some antidepressants, including SSRIs and tricyclics, blunts or reduces the psychedelic effect of these chemicals. So, as I said, the initial somatic reactions, within 10 to 30 minutes post-ingestion include these sympathomimetic signs and symptoms. I won't read those aloud. You can see them there. Also, we notice insomnia with REM rebound the evening after the psychedelic experience. Now, when we talk about the psychedelic experience itself, that experience is the product of a complex interaction of the drug and the person's external environment and their internal state. We talk a lot in psychedelic research and in psychedelic literature about set and setting, where set is the person's internal frame, their personality structure, which tends to be a trait variable, one that is long-lasting over time, and how they are now, or their state of being, those variables that tend to fluctuate hour to hour, day to day. And what's interesting to note is that in the psychedelic experience, what we see change is not only a person's state variables, but there's also potential to change the more longer lasting and harder to change traits A person's set also consists of their previous experiences with psychedelic drugs and their current intention of use, what they want to get out of the psychedelic experience when they're going into it. The setting is the external frame. It includes the physical environment, the social or interpersonal milieu, the atmosphere or ambiance that is set in the physical environment, and also the expectations of any other people who might be around. So you have the physiological effects of the drug, plus the set, plus the setting. That gives you the psychedelic experience. That experience can be divided into 5 main categories of effects. That of mood and affect, interpersonal behavior, sensory and perceptual effects, intellectual function and reality testing, and intuitive effects. First of all, talking about mood and affect, psychedelics cause a lability of affect and typically an increased intensity of emotions. A lot of users will describe a sense of well-being, anything from mild euphoria to very strong feelings of omnipotence. We also see an increase or decrease in the level of anxiety, which can coexist. An increase in anxiety can coexist with the feelings of euphoria and omnipotence. There's an increased concern with immediate events and sensations and a marked lack of concern for things in the future and past. I'm going to be switching back and forth between describing these categories and then describing what we've seen in our subjects thus far. All of our subjects here at the university, 4 of them thus far, have endorsed increased intensity of their emotions and have had states of euphoria at some point during their 4 sessions that they've had with us. The second realm is that of interpersonal behavior. Psychedelics cause increased sensitivity to interactions with others, which leads either to their being very easily hurt, feeling neglected or rejected, and or they feel an enhanced connection to the people around them. Thus, the term empathogenic is sometimes used to describe these compounds. And all of our subjects, again, endorsed at some point in time a sense of closeness, not only to the sitters who were sitting in the room with them, but also immediately after the experience when they went to our inpatient ward. They had a sense of closeness, a sense of empathy with staff, nurses, and other patients on the ward. Now, the sensory and perceptual effects are those that a big deal is made of for many people. Psychedelics cause an increased sensitivity to existing sensory stimuli. They cause illusions and hallucinations and other perceptual distortions. One of the most remarkable type of perceptual distortion is that of synesthesias, which is crossover of sensory modalities. So psychedelics cause people to taste music or to hear colors or see music, taste colors. And there's also a profound change in one's sense of time. Time seems to stop, seems to go backwards, seems to speed forward. Time takes on a very dreamlike quality when one is in the psychedelic experience. And also the overall framework of the world becomes very fluid and maybe even at sometimes unstable, and startlingly so. So our subjects, of course, had no lack of quotes about the sensory and perceptual effects that they were experiencing. One subject endorsed waves of circular light. One person described the room as turning light blue, yellow, and green. Almost all the subjects described the music that we have in the room as intense yet relaxing. One subject talked about light tingling all over her body. One guy described what I guess were synesthesias by saying that the visuals that he was having were stimulated by the music and the note changes. And the same guy described purples, greens, every color, lots of color. He saw Ganesha laughing, saw faces, skulls, and neon floating patterns. So he was obviously having several distortions and illusions and hallucinations all at once. Francisco is signaling to me to remind, I'm going to talk about the methods of our own research later on, but in talking about this, I want to remind or to tell everybody that during the experience, people are wearing eye shades. They're wearing eye shades that have headphones built into them, so external sensory stimuli are blocked off. So all of these changes that people were describing were coming from, were originating internally. The next realm of changes that we see is in the realm of intellectual function and reality testing. Commonly what is seen as a lability of thought form, which is often interpreted as either associational disturbances or as intuitive leaps. During the peak of the experience, some disorganization of thought content or memories can happen, and the psychedelic experience tends to cause altered interpretation of concepts and of complex experiences. All of our subjects described unreal experiences, but all of them were able to remind themselves and were able to remember that they were under the effects of a drug when they were undergoing these experiences. And finally, talk about intuitive effects, which are relatively frequent and very highly valued by users. Intuitive effects include feelings of oneness with the earth, with other people, with the universe, a feeling of, or a sense of having a deeper understanding of life and one's history and one's experiences. This realm covers mystical and religious and transcendental experiences, and also philosophical thinking. You know, questions like, why are we here? What's it all about? These typically come up in the midst of trips. One subject described psilocybin as a great teacher. He said that he was shown that some things in his life are extraneous and unnecessary. He referred to the compulsions that he was having as part of his obsessive compulsive disorder, but also saw bad habits like smoking and junk food as just extraneous and unneeded and perhaps even harmful to his state of well-being. I'm not going to read this quote aloud because we actually have a videotape of the subject who talked about seeing Jesus, and I'm going to show that to you at the end of this talk. Dr. Comment?
In the last slide, you were describing this as kind of almost like meditation. Was there any control in the study, taking subjects, not giving them the substance, just giving them the eye shades, the music, etc., and seeing what would happen with them?
We don't have a control group per se built into the study. We do have active placebo built into the study. The subjects receive 4 doses, one of which is a very tiny dose of psilocybin meant only to stimulate some physical reactions, but not to stimulate an actual psychedelic experience. And we can talk a little bit more about that later. And here are 2 well-known fellows having a psychedelic experience, Andy and Barn. Andy is saying, hey Barn, have you ever really looked at your hands? So now we'll talk about adverse reactions to these drugs, because certainly psychedelics are not without their risks. The most common are probably somatic discomfort, which pretty much everybody experiences. Then you have your bad trips, which are really panic reactions to some aspect of the experience. And finally, we have our DSM-4 defined disorders. DSM-4 talks about the hallucinogen use disorders, that of hallucinogen abuse and dependence, and then the hallucinogen-induced disorders, including intoxication, persisting perception disorder, which we'll talk about flashbacks here in a couple of slides, intoxication delirium, intoxication or induced psychotic disorder with delusions with hallucinations, hallucinogen-induced mood disorder, anxiety disorder, and of course my favorite, hallucinogen-related disorder not otherwise specified. And this is a good place to note that in the case of hallucinogen persisting perception disorder, there's not been one case reported with use of psilocybin. That tends to occur mostly with LSD. So when you see an adverse event in the emergency room in the clinic, the first thing you want to do is to reassure the person. You want to reduce external stimuli, and you want to just basically provide supportive care. You really want to avoid any intrusive, invasive procedures unless it is unclear to you what they've ingested or how much they've ingested. If you do need symptomatic treatment with medicines, first-line treatment is with benzos or atypical antipsychotics. The atypicals, particularly, I looked over Stahl before I came over here, and I think it's Giadon and Zyprexa that have not only serotonin 2A blocking activity, but also serotonin 2C blocking activity. All the atypicals have 2A blocking, but it's those two that have also affinity for the 2C, so it might make sense to use those as first line. If that doesn't work, then you want to use a serotonin antagonist such as ritonserin for treatment. Now we'll talk about flashbacks. The definition or the description of flashbacks is transient, spontaneous recurrences of the psychedelic drug experience. That's not a fast and true rule. Some flashbacks, or particularly perceptual disturbances like we see in perceptual disturbance disorder, can be just long-term, non-remitting. The incidence of flashbacks varies widely in the literature. The range is anywhere from 15 to 77%. And I think one reason for that, that wideness, that variation in the incidence numbers, is because flashbacks aren't necessarily a bad thing, that there are users out there who can have very positive, pleasant flashbacks. That's why one of the terms amongst users for a flashback is a free trip. One thing that we do know is that flashbacks, at least the unpleasant sort that psychiatrists are usually called in to treat, because we usually don't get called in for the good flashbacks. Flashbacks are more likely in people with pre-existing psychopathology and also with a greater degree of suggestibility. What exactly causes these things is unknown. Some hypotheses include that flashbacks, particularly those that are emotional, are a kind of PTSD reaction to a very strong emotional event. Certainly somebody who has a bad trip, that can be considered traumatic if it's bad enough. But again, talking about positive experiences, if someone has a very strong positive experience of any sort, that can also be attached to or related to re-experiencing or having strong memories of that positive event. And you don't need to have, take psychedelics to have a strong positive event occur in your life. Also, some other ideas are that the persisting perception disorder is a form of visual seizure. There's also an idea that maybe flashbacks are a conditioned response to arousal, that maybe flashbacks are exacerbations of personality features that were there to begin with, or a more psychodynamic explanation is that the person's defensive ego functions are incapable of suppressing unacceptable memories of conflicts that were brought on during the experience. Treatment of flashbacks includes using SSRIs, atypical antipsychotics, clonidine, and clonazepam. The latter two actually have more evidence in the literature these days than the former two, so clonidine and clonazepam are actually first-line treatment for flashbacks. And then finally, we talk about what is probably the most serious adverse effect, which is hallucinogen-induced psychosis. And this, of course, is psychosis preceded by known use of hallucinogenic drugs. The incidence of psychosis is, the mean incidence is 2.7%. The range is 0.08 to 4.6%. And it's very important to note that that is in a controlled setting, in a clinical or research setting. Now, the lower end of the range, towards the 0.08 number, that was in normal, healthy volunteer populations. The larger end occurred more in populations with pre-existing psychiatric disorders. Psychosis is associated with poorer premorbid functioning, which kind of makes sense. History of psych illness, again, kind of makes sense. And polydrug abuse. So what we're talking about here is a kind of diathesis model where somebody has a pre-existing biological predisposition to psychosis that is uncovered by the chemical and or psychological effects of the drug. A more chemical etiology is that there's a lot of serotonin aggregations. So the hallway in the emergency room is definitely not a place for these people, but they get put there anyway. And if you need to calm them down in the acute phase, benzos and atypicals are again first-line treatment. Here's the part where you get to win a free beer. First person who can name this guy gets a free beer. Very good. Very good. So if you come to happy hour, you get a free beverage. This is Syd Barrett, who was one of the founding members of Pink Floyd. I was going to talk a lot about him, but I figured it would be kind of unprofessional, and because nobody really knows what happened with Syd. All we know is that he was one of the founding members of Pink Floyd, and somewhere around 1967 started developing really odd behavior. And God knows why that was, but some people tend to attribute that to lots and lots of acid. So finally, we're going to mosey on to history of use. First, going to talk about psilocybin. Psilocybin was used ritually in Central and South America. There are cave paintings in those areas with mushrooms very prominently displayed, dating back to about 5000 BC. So use of psychedelic intoxicants goes back pretty far in history. There's historical evidence that the Mixtecs and later the Aztecs used psilocybin in their religious rituals. The Aztecs called psilocybin mushrooms teonanacatl. Am I pronouncing that right? Anybody? I'm looking at you, Francisco. Say it for me. Teonanacatl. Okay, cool. So anyways, that translates literally to flesh of the gods, or it was also called the wondrous mushroom. So all this was going on until the Europeans came along, the conquistadors, and they didn't like the looks of anything that was not purely Christian, so they forbid its use among the natives. Nonetheless, the Aztecs continued to use the mushrooms in secret ceremonies, and in the mid-16th century, a monk named Bernardino de Sahagún, I hope I'm saying that one right too, but described an Aztec mushroom ritual in his writings. By the early 20th century, because the mushroom cults, the mushroom religions had gone underground, Americans and Europeans actually debated the existence of psychedelic mushrooms. There was a school of thought that thought that Sahagún had mistaken dried peyote buttons for mushrooms. But in the 1930s, a guy named Robert Whiteliner observed a Mazatec mushroom ceremony, and then it wasn't too long before, in 1955, two guys named Wasson and Richardson were the first white boys to participate in a mushroom ceremony. They went to a woman named Maria Sabina, who was a Mazatec curandera, and she shared with them the secrets of the magic mushroom, which was the name of the 1957 article that Wasson wrote for Life magazine. In that same year, Albert Hofmann isolated psilocybin and psilocin, the active ingredients in psychedelic mushrooms, and invented a technique for synthesizing those chemicals in the laboratory. Now we move on to mescaline, which, as I said, is the active ingredient in peyote cactuses. There's evidence of use of mescaline dating back to 1000 BC, a little further north than psilocybin in the areas that are now Mexico and Texas. But once again, the conquistadors came along and thought that the natives were practicing a kind of witchcraft, so forbid the use of peyote buttons. So it took till 1845 for European botanists to classify peyote. In 1887, this is really interesting, Parke Davis distributed dried peyote buttons for medicinal use. Is there anybody here from Parke Davis today?
Pfizer owns them now.
Oh, really? Oh, I'll have to talk to our Pfizer dudes. Cool. So then in the late 1800s, we saw a spread of peyote use northerly into the mainly Native American populations. In 97, mescaline was isolated by Arthur Hefter, and in 1919, a method was found to synthesize it in the lab. 1918, the Native American Church was formed. In 1930, there were at least 12 states that outlawed the use of peyote. Across the ocean in Italy in 1931, a guy named Dr. Baroni started using mescaline as an adjunct to psychotherapy. 1953 and 54 saw the publication of Aldous Huxley's Doors of Perception, which of course is Aldous Huxley's first-person account of using mescaline, and he gives some pretty detailed descriptions of his experience. It's a good read if you have some time. In 1960, the federal government gave Native Americans legal access to peyote, which was good because in 67 they banned everybody else from using it. The use of the ergolines now, mainly because this is the only example of hallucinogens being used ritually in the ancestors of Western European civilization. Starting in 1500 BC and lasting until about 300 AD, when again the Christians started getting more heavily involved in Roman politics, there was a ceremony called the Eleusinian Mysteries. This was an annual celebration to honor the goddess Demeter, who was the goddess of the fields and of grain. There was a pretty exclusive invitation list in its 1800 years of life. Attendees at this celebration included people like Homer, Cicero, Aristotle, Plato, Sophocles, Pindar, and Aeschylus. And they would get together for 2 or 3 days and they'd drink something called kykeon, which, judging from what has been written about this and what has been described, was probably a grain-based brew whose hallucinogenic properties were derived from rye ergot fungus. Now we hop ahead a few hundred years to 1943, when a chemist named Albert Hofmann was synthesizing rye ergot derivatives for use in medicine. On April 16th, he accidentally ingested LSD-25, an agent he developed as a blood stimulant for Sandoz. 3 days later, he purposefully ingested LSD, about 250 micrograms. And again, he wrote a really nice account. He went for a bike ride. He rode his bike from like work to home, and to him it took about 5 years to get there. Again, really entertaining reading. So it didn't take too long for the CIA over here in the US to find out that LSD was around and that it had some pretty profound effects on the human mind. So in 1953, the CIA started their MK Ultra experiments. Now, these were not experiments in the usual sense that we think of them these days, because these days, we insist on these things like consent to participate in experiments. The CIA was going around and giving people LSD without their knowledge. That actually resulted in 1 or 2 suicides. So finally, in '63, that kind of stuff was shut down. While the CIA was goofing around, Tim Leary started some more legitimate research work at Harvard. 1962 came around, and once again, Congress started hearing about this LSD stuff and thought that, well, if it's powerful and can be used as a weapon, then we should probably start putting restrictions on it. 1963 is when black market LSD started hitting the streets and the college campuses. It was that same year that Tim Leary was fired from Harvard. He later went on in 1966 to found the League for Spiritual Development, which was based in Millbrook, New York. And by 1970, 1 to 2 million Americans had used LSD. And that leads us into talking about the clinical trials of the 50s and 60s. Back between 1950 and 1960, Stahl, Osmond, and others were using LSD as adjuncts to psychotherapy. Osmond's first reason for doing this was kind of unusual. He was treating alcoholics, and he had noticed in his clinical work that the alcoholics were most likely to abstain permanently from alcohol were those who had been through very violent and severe DTs. So he saw LSD as a way of recreating the DT experience in a safer way than actually putting somebody into DTs. So where things sort of fouled up for Osmond is that he gave his patients the LSD and really tried his hardest to make them have a really bad experience to scare them into not drinking alcohol again. But most of the patients had very positive experiences. And also had tended to have a sort of shift in their paradigm, a shift in their thinking and in their perspective on their drinking, to the point that the subjects who were given LSD tended to do a little better in terms of remaining abstinent than the people who didn't. 1960 came along, and Cohen at UCLA published a safety paper on LSD. They looked at 5,000 subjects who collectively had taken 25,000 trips. So some pretty good numbers. Per 1,000 LSD ingestions, there were 1.8 psychotic episodes, 1.2 attempted suicides, and 0.4 completed suicides. Those numbers led Cohen to declare LSD an astonishingly safe drug, and that opened the doorway to more human clinical experimentation. One of the most well-known experiments is the Good Friday experiment. It was conducted in 1962 by Walter Pahnke. He took 20 theology students who were psychedelic naive, who had had mystical experiences in their past at some point. He split them into two groups. 10 of them received psilocybin, a pretty healthy dose, and 10 got an active placebo. They got nicotinic acid, which, if given at a high enough dose, causes some tingling and some physical sensation, but isn't, as far as I know, a psychedelic. Gave them the psilocybin and active placebo in a very supportive religious setting. They actually did this in a church. And when all was said and done, 4 out of the 10 people in the psilocybin group had had a mystical experience that day, whereas none in the placebo group had a mystical experience. Later on in 1991, Rick Doblin of MAPS did a follow-up study and talked to most of the people who'd been involved in the Good Friday experiment. And it turns out that most of them from that day had had long-term benefit. Either it had changed some aspect of their relating to God or their conception of their religion. And none of the people who received psilocybin had any long-term negative effects. Next was the Concord Prison Experiment, also pretty well known in the literature. This was run by Tim Leary in 1961 through 63. What he did was he did psilocybin-assisted group therapy with prisoners, and his goal was to reduce recidivism. So what they did, they had 12 group sessions over 6 weeks, and for 2 of those sessions, the prisoners received psilocybin. I think also the facilitators took psilocybin. Research was a little different back then. But Leary, in his paper, reported significant improvement in the prisoners' recidivism rates. But later on, again, Rick Doblin did a long-term follow-up study and found that the improvement wasn't as great as Leary had said, and was in fact non-significant statistically. And finally, we come to the Spring Grove experiments. Spring Grove was a state hospital in Maryland, or is a state hospital in Maryland. I actually went to their website, and they had a history of Spring Grove from its, they founded it back in 1600, 1700, and there was no mention of Stan Groff and Walter Pahnke doing these LSD experiments in their hospital. I can't imagine not wanting to talk about this in public. But anyways, so Walter Pahnke and Stan Groff and others in 1963 started the Spring Grove experiments. These were NIMH funded. They received $4 million to conduct these experiments. They gave LSD to alcoholics and addicts, and that of course was based on Osmond and others' experiences with using LSD in treatment of addictions. They also gave it to neurotics and terminal patients. Now, with those last 2 groups, an endpoint is difficult to define, but in the addicts, they did see a significant reduction in relapse rates. The same kind of work continued at both Spring Grove and at the Maryland Psychiatric Research Institute until it finally shut down in 1977. And now we talk about psychedelic prohibition. As I've said before, in '62, Congress started putting restrictions on LSD. This looks like something that they should control a little bit. In 1966, Senate hearings were actually held, and as a result of those, the FDA instituted further restrictions on use and research with LSD. And then in that same year, LSD was made illegal in California. In '68, they stiffened penalties for having LSD, using LSD. And in 1970, that saw the birth of the Comprehensive Drug Abuse Prevention and Control Act, the Part 2 of which was the Controlled Substances Act, and the schedule system, which you all, well, most of you probably know about, Schedule 1 through 5. Schedule 1 being substances that have no therapeutic or research potential, and without much thought, psychedelics and marijuana were put into Schedule 1. It seems to me that a lot of the decision-making around that time was based on hysteria and fear rather than looking at the available scientific evidence, which of course was still preliminary at that time. But to sort of just take a hatchet to all the work that was going on in research circles, it seemed a little bit like an overreaction, at least in hindsight and from my perspective. Maybe we can talk about that later. So between 1970 and 1990, most legitimate work with psychedelics was done as bench work and as animal research. And like I said, a lot of the decision-making, a lot of the thinking at the time was based on fear and some irrationality. And as a result, there were several myths regarding LSD use and LSD and health. Things like chromosome damage. This hit the front pages when a study suggested that there might be a link between LSD and chromosome damage. All over the media, that LSD causes irreversible damage to people's genome. 1 or 2 years later, more detailed, better designed studies came out and showed almost indisputably that LSD was not responsible for chromosome damage, and that wasn't reported nearly as much as the initial report that LSD was responsible. So chromosome damage doesn't happen. Same thing with leukemia. There was at one point a link hypothesized between certain kinds of leukemia and LSD. That again never really happened, wasn't true. There was a story out, an urban myth, about two young college students who took LSD and then stared at the sun until they went blind. I think it was sometime in the mid-70s that a politician in Pennsylvania came clean and said that he made that story up to scare kids out of not doing drugs. So again, not true. I think we've all, or most of us, have heard the story about children's tattoos being laced with LSD, so be careful when you go out on Halloween, and if anybody gives you one of those lick 'em stick 'em tattoos, you better throw it away. Once again, there's been not one reported incidence of this ever happening. And finally, there's rumors, particularly among college students, that strychnine is somehow involved in the manufacture of LSD, that it's either required to kick LSD into your system or that it's needed to keep LSD sticking to the blotter paper. There was one report of a batch of LSD being adulterated with strychnine, but that was powdered LSD. There's never been a case of blotter acid being contaminated with strychnine. So again, that's something of an urban myth amongst users. Oh. How do I get back to that? There we go. For those of you who can't read it says, "Sorry, son, but for you to understand what happened, you have to first understand that back in the 60s, we were all taking a lot of drugs." So now you know that's not true. So now we'll talk about some of the more recent work that's been done. Psychedelic research is gradually coming back. In Switzerland, between 88 and 93, Bloch et al. Did a retrospective study with 171 subjects looking at MDMA and LSD-assisted psychotherapy, because these are legal modalities of treatment in that country. In 1996, Spitzer looked at the cognitive effects of psilocybin and found that it increased indirect semantic priming. In 98, in Germany, Hermle et al. Looked at blood flow and cerebral laterality with mescaline. And finally, in 99, Guzoulis, Mayfrank et al. Looked at the neurometabolic effects of psilocybin and some other drugs in healthy volunteers. There are currently projects in progress or under development. Kurland at Baltimore is looking at using LSD in the treatment of cancer patients. This project is currently on hold at the FDA. Matthew in Durham is looking at using mescaline in healthy human volunteers and examining religious experiences. Charles Grobe at UCSD just got approval for using psilocybin in the terminally ill. Vollenweider in Switzerland is doing basic dose-response safety studies with psilocybin, and Torsten Passy and others in Germany are doing a study using healthy physician volunteers and looking at some of the neuropsychological and neurobehavior effects of psilocybin. Drugs. There have also been recent or will be studies with ecstasy, with MDE, DMT, ibogaine, ayahuasca, ketamine, and salvia divinorum. If you are interested in these studies, you can go to the MAPS website, maps.org. It's a pretty fascinating website. It has a list of all the current and recent research studies going on. And finally, we come to our own work. Our research subject is our research study is entitled "Effects of Psilocybin in OCD." Started out in 1997 when the good Dr. Moreno and Dr. Delgado were seeing a patient together, and this patient had very treatment-resistant and severe obsessive-compulsive disorder. And he happened to mention to them that, gee, docs, when I take psilocybin, it tends to make my OCD better, not just during the trip, but for a period of time afterwards. So our two good doctors thought that was really interesting and got it published as a case report in the American Journal of Psychiatry. Now, psychedelic-induced relief of OCD symptoms is supported by the anecdotal evidence, because if you do a lit search, you find that there are several other case reports like this one with LSD use and with psilocybin use. It makes psychopharmacological sense that because these drugs are very potent serotonin agonists and affect that system in the brain, remember that that's the same system that we are enhancing or tweaking when we treat obsessive-compulsive disorder. So in this study, our long-term objective is to evaluate the safety and tolerability of psilocybin in human subjects. This is an FDA phase 1 study, which means that the primary goal is establishing safety in humans. And please note that we're looking these days at a primarily pharmacological, not a psychotherapeutic mechanism of action. Some short-term questions that we hope to ask. We hope to gather pilot data to point us in the right direction regarding the answers to these questions. Does psilocybin lead to a reduction in the symptoms of OCD, and that we can measure? And is a full hallucinogenic dose required to demonstrate a significant reduction in the symptoms? Meaning, does a person have to have a dose that gives them a full-blown psychedelic experience in order to experience relief of their OCD? You're just stretching?
Yeah.
So here are some inclusion and exclusion criteria for the study. Subjects have to be 21 to 65 years old. They must be prior treatment failures, meaning they have to have taken standard medications, SSRIs or anafranil, at full doses for at least a month, if not longer, and have not had a significant reduction of their symptoms. They must have no comorbid psychiatric disorders, including no active substance abuse or dependence, and no personal or family history of psychosis. They must have prior exposure to the psychedelic experience, and that's mainly for informed consent issues. This was discussed in our IRB, and it was decided that in order for somebody to give full informed consent, they should know what they're getting into. Also, our subjects have to be free of significant medical illnesses and can't be on any kinds of medications during their testing sessions. And we do an EKG comprehensive metabolic panel and a drugs of abuse screen. So this is a pilot study. We have 10 subjects and no controls. The control is built in with an active placebo. Each subject receives 3 dose levels, 0.1, 0.2, and 0.3 milligrams per kilogram. 0.2 milligrams per kilogram is the average dose at which most people will have a psychedelic experience. So that's the sort of threshold dose. 0.1 milligram per kilogram is a sub-threshold dose, and 0.3, of course, is a supra-threshold dose. The active placebo of 0.025 milligrams per kilogram, like I said before, is inserted to give the physiological effects, but hopefully not to induce a full-blown psychedelic experience. Our subjects, we have a very nice room up on the 7th floor. It's probably the most cozy room in the hospital. So they sit there with two sitters present at all times. They wear the eye shades, as I described, and they listen to music. Back last year, Stan Groff and other psychedelic researchers from around the country came here. Stan gave grand rounds, and we got to meet with these folks who are experts in the field, and they gave us lots of advice on how to treat our subjects, how to make the setting as ideal as possible. And so that's where we got these ideas for the music, the eye shades, and the sitters. We administer the Yale-Brown Obsessive-Compulsive Scale and a visual analog scale right before the dose, and then at 4, 8, and 24 hours. We administer Strassman's hallucinogen rating scale at 8 hours, and sessions are 1 to 2 weeks apart. Yeah?
For the 0.2 mg per kg thing, did the people who synthesized psilocybin do this and have people subjectively rate their experiences to come up with that number? Where did that come from?
That's a number that was culled from the literature and was the dose previously used in some of the early experiments, like the Good Friday experiment. They used 0.2 mg per kg. That's a good question. I don't know if they were using synthetic. Probably. We're using synthetic psilocybin. We're not using mushrooms in this because it's easier to quantify, and it also ensures no impurities are being given. So right now our results, well, we haven't broken the blind. These are very preliminary results that I'm going to share with you. We've administered a total of 13 doses. All of these doses have been tolerated very well, and we have not seen any serious adverse effects. Out of our 4 subjects, 3 had improvement in their OCD symptoms during the acute psychedelic experience, and out of those, 2 have had improvement lasting days to months after their final dose. Here are some of our funding sources that I'd like to thank now. The Hefter Research Institute, the Multidisciplinary Association for Psychedelic Studies, and the Nathan Cummings Foundation have all donated money to our research project. So he's saying, yes, I believe there's a question in the back. And I'll just put this stuff up for your perusal while we're talking about questions and such. So does anybody have any? I'm assuming that's good. Okay, so as Dr. Mishashik said, the title of today's talk is Therapeutic Potential of Psychedelics. But I'd like to start out with a picture of Dr. John Mishashik in rare form.
I guess I went a long time without anyone seeing me.
I was hoping that you'd be introducing me and not Chelsea. So the next thing I want to do is I want everybody in the auditorium to raise their right hand and to put their right index finger in the air. Everybody do this. In order for it to work, everybody's got to do it. Now with that right index finger, I want you to go to your cell phone or pager and put it on stun vibrate so it does not make a noise and distract me. I hate it when that happens. So today I'm going to go over, first of all, address the topic of what are psychedelics, how do you define the term, what chemicals exactly constitute a psychedelic, what are their pharmacological actions, what is the psychedelic experience like and what does that consist of, and finally we'll talk a bit about adverse effects of psychedelics. We'll then talk about the...
Well, the time has finally come for Dr. Happy Hour to present at Grind Rounds. For those of you who do not understand my reference to Dr. Chris Wiegand in that manner, let me read an email sent this afternoon to the members of our department. I quote, "Happy hour this week will be at the Shanty, 4th Avenue and 9th Street, after my grand rounds. Pay attention at grand rounds for an opportunity to win a free beverage. Chris." It's not only a pleasure to welcome Dr. Chris Wiegand to grand rounds, but also a special guest, Stephanie, who I assume is here in a supportive role. Is that right? Okay, good. Dr. Wiegand is a graduate of the Virginia School of Medicine in Charlottesville, Virginia, where he incidentally and not surprisingly was elected to be the class social chair from 1996 through 1999. In his years with us in our program, he has been very busy both within our department and apparently outside our department as well. In addition to attending his residency training requirements, he serves as an instructor for the psychopharmacology seminar for third-year medical students. He is a volunteer facilitator for the first-year medical students work group, and also this year he received the Pfizer Resident Award at the APA annual meeting in Philadelphia. Last year he served as a member of the Internal Review Committee for the Department of Neurology, and also was a member of our department's Child and Adolescent Faculty Selection Committee and a member of our Resident Selection Committee. In 2000, he was the Eli Lilly Fellow at the U.S. Psychiatric and Mental Health Congress. He additionally participated in a psilocybin study with Dr. Moreno for the past 2 years, which, along with his numerous happy hour engagements, I'm sure, has influenced his choice of topics for this afternoon's grand rounds. His talk is entitled "The Therapeutic Potential of Psychedelics." Dr. Wiegand.
Thank you, Dr. Mishashek, for that warm welcome. I'm sure Stephanie's thrilled about that, too. I have to attach my microphone. The tryptamines include DMT, psilocin, psilocybin, and the active ingredient in bufo toad venom, which is 5-methoxy-DMT. The next family is the ergolines, which includes LSD and its natural and synthetic analogs. The next group is the beta-carbolines, which include harmaline, which is one of the active ingredients in ayahuasca. The phenethylamines include mescaline, which is the active ingredient in peyote. And finally, we have the phenylisopropylamines, which includes DOM, which was popular back in the 60s, also known as STP. Today, we're going to talk about psilocybin, LSD, and mescaline because these are the most widely used psychedelics, and we have the most clinical and research experience with them. I'm not going to talk about MDMA or ecstasy because that is an entire lecture unto itself. History and prehistory of use of some of the major hallucinogens. We'll move on to talk about the clinical trials of the 50s and 60s, the age of psychedelic prohibition, and the more recent clinical trials from the 1990s until the present. And then finally, I'll talk about our own research. From the Greek, it literally means mind manifesting or mind revealing. The Oxford English Dictionary defines psychedelic as producing an expansion of consciousness through greater awareness of the senses and emotional feelings and the revealing of unconscious motivations. Psychedelics go by a variety of other terms as well. The term hallucinogen, psycholytic, psychotomimetic, entheogen, empathogen, and enactogen are also used. Which term you use depends on which one you favor and also how you're using the chemical. A more pharmacological definition of psychedelic is any agent that causes alterations in perception, cognition, and mood as its primary psychobiological action in the presence of an otherwise clear sensorium. The chemical families which constitute psychedelics, there are 5 main families. The tryptamines fall into the bigger family of the indole alkylamines.